Greetings and welcome to today's SPH Alumni Webinar, What Happens After Substance Abuse Recovery Programs End? Long-Term Outcomes for Women in Recovery. I'm Sarah Pennebecker, Assistant Director of Alumni Relations at the School of Public Health. Thank you to all alumni, students, and friends of the School of Public Health who made time to join us live today. Today's webinar is made possible by our SPH Alumni Society Engagement Committee who helped plan the webinar. Thank you to our committee members. This webinar is part of our 2019 Public Health Lecture Series focused on substance abuse in Minnesota. We invite you to join us for 2 more events happening later this month. Details can be found on our website at sphalumni.umn.edu. Questions are welcome and you may submit them at any time. Please type in the questions in the questions panel on the right-hand side of your screen under Q&A. We'll be monitoring questions along the way, so please submit your questions or comments at any time. And now for our webinar on long-term outcomes for women in recovery. I'd like to introduce the presenter of this webinar, Stephanie Nelson-Dusek. Stephanie is a research scientist with Wilder Research. She works on a broad range of topics including child welfare, trauma, substance abuse and recovery, and housing and homelessness. She manages the Women's Recovery Services Initiative, in addition to working on other studies aimed at improving the well-being of children and families, including a study of innovation in child protection practices, an analysis of short stayers in the Minnesota foster care system, and an evaluation of a national strategic initiative to improve the lives of families impacted by maternal incarceration. Welcome, Stephanie. We'll turn the webinar over to you.
Thank you. Thanks, Sarah. Can you just confirm that you can hear me? Because I'm a little nervous about that actually working.
Yes, I can hear you. And if people can't, please type that in the chat and I can troubleshoot with you.
All right, great. Well, thank you so much, Sarah, for having me here, and thanks for all of you for joining the webinar today. Like Sarah said, there's the chat function, and I'll try to address questions as I'm going, although Sarah can chime in if I'm missing stuff too, if I just get on a roll. Our team always loves the opportunity to present the data that we collect and share it so we can make or help others make decisions based on that data. So we're really excited to present this research to you today. And I just want to say that I think as far as our team knows, at least, there are 6 of us that work on this project, that this is a really unique study. As far as we know, there's not another one quite like it, where we really dig into some longer-term outcomes for women in recovery. And so we have really rich data to share and some trends that I think hopefully you'll all find interesting, and we'll raise some good discussion questions as you go back to your work today and moving forward. So as Sarah said, I'm going to talk about a project that Wilder Research did with the Minnesota Department of Human Services. And it's a 5-year grant initiative that looks specifically at key outcome areas for women in recovery. And, let's see if I can advance the slide. Okay. So there's me again. I wanted to include a couple of pictures just so you can sort of see who I am and where I work. I'm at the Wilder Center in St. Paul. You'll notice that is not a recent photograph. I think that was probably taken in some really nice summer months that is not now. If you're familiar with our building, you'll know that there's a 2-story mound of dirty ice outside, and yes, this was more hopeful than taking a current picture. But so that's me, and that's where I work, and I wanted to just give an overview of the initiative today, who was involved and what we were doing, talk about the key outcomes of the women that were involved in the grant initiative, and then talk about what works for those women. That's really sort of what we hope to get at with any data is, so we've collected it, we've analyzed it and reported it, but what now? So a really high-level overview of the initiative is that it's, like I said, it's a 5-year grant that it's funded through some federal dollars that are passed through to the Department of Human Services. And then the Department of Human Services distributed that money to organizations around Minnesota who serve pregnant and parenting women with substance use disorders and their families. And these programs are, when they get a grant from the Department of Human Services, they have to provide comprehensive, gender-specific treatment and recovery services to women and their families. And two of the grantees that are served under this initiative, or two or three actually, also provide culturally specific programming to American Indian women. So grantees are dispersed around the state. They serve women, and in some cases culturally specific programming, but with the overall purpose of ultimately improving outcomes for the women that they serve by their program and their children. This grant initiative that we're talking about today was from July 2011 to June 2016, so that was a 5-year cycle. The data that you'll see throughout here are actually more from 4 years of that study because there was a pilot year where we were kind of testing out the questions that we were asking and the processes. But we also have another grant, a second cycle that we're currently in now. So we're still collecting all of this data and learning more about the programs that the women that programs serve. But this is really looking just from 2011 to 2016 data. So I just wanted to make that clear. Okay. Again, this is the main partners of who are involved. We have the federal SAMHSA dollars that are passed through to the Department of Human Services. And then in the previous cycle, the dates I just showed, there were 12 treatment and recovery service providers. And we know that, we're really lucky as the evaluator that we get to meet with the people who work in these programs on a pretty regular basis and see the hard work that they're doing. Here, I'll move it to the one slide. You can see the 12 programs represented here. They are working hard to serve women and their families, and we get to hear stories from them when we meet with them and really learn about the good work that they're doing. So it's a really a combined effort between, the federal dollars, the state of Minnesota, and the treatment and recovery programs that are doing this work. So as I said, this map shows the 12 programs around the state. The tricky thing about evaluating 12 programs is that the service models, no program is exactly alike. So the service models can vary a little bit by site, but in general, the 4 bullets that you see on the slide here, treatment and recovery, basic needs and daily living, mental and physical health, and parenting, those are the types of services that are common across the 12 programs that have this grant. And I want to just focus a minute on what we mean by treatment and recovery because, it's one of those are some terms that people may have different definitions for. But DHS and SAMHSA talk about recovery as the process of change through which individuals improve their health and wellness, live self-directed lives, and strive to reach their full potential. So anyone who's worked in this field or has experience with people in their lives who are in recovery, we know that there are many different paths to recovery, and that it's a long-term and ongoing process. And similarly, treatment includes services that are intended to provide those in recovery with prevention and care. So it's a broader term, not just about care, but prevention and care, and addressing all aspects of being substance-free. So your physical health, your emotional, cognitive health, and behavioral health. Examples of treatment and recovery services that organizations provide under this grant include case management, screenings, assessments, care plans, things like that. We also know that these programs do a lot of work, like I said, with basic needs and daily living, so housing, transportation, job training, child care, and also with mental and physical health services, like getting their kids immunized or taking wellness classes and parenting classes. They're doing a lot of different types of work to get at that treatment and recovery. Like I said, the organizations that you see represented on this map just do a tremendous amount of work with women and their families. And so being able to work with them and hear from them is always really nice. You know, we do a lot of data collection on our end, looking at numbers, but being able to hear, especially in the follow-up interviews that we do with women who are served by programs, is really nice to hear in conjunction with the numbers, the stories that we're hearing from women served. So I'll just talk briefly about what our job is as the cross-site evaluator for this initiative. We look specifically, we collect the process and outcome information, meaning we look at both how the programs are being implemented and how women are doing at different time points. And then we provide technical assistance or help to the grantees who collect the data. So grantees will collect data from women at intake and closing, and then put that into a database that we created. And so we help them sort of troubleshoot all of those issues that go into database management and just working to help women answer the questions that we've agreed on. And then Wilder does follow-up phone interviews with women 6 months and 12 months after they've left their program. So we're doing a lot of data collection, a lot of analysis and reporting, and then at the very end of the grant cycle, we had our economists do a return on investment report. So that's reported separately. We're not going to talk about the return on investment here, but we're happy to share that information too if someone is interested in that. So who does this evaluation include? Like I said, it's about 4 years worth of data between 2011 and 2016. And we see that over the course of those years, the programs that you saw on the map served about 3,000 clients and just over 6,000 children. People can come into their programs a lot of different ways. Some people come in through child protection or the criminal justice system. Some are self-referred or referred through a different program. But this shows a breakdown of where kids were living at intake when they came into their program. Most were living, or 47% were living with mom, dad, or both of their parents. Almost 30% were with another family member or friends, and then 16% were in a non-kinship setting. This is a quick sort of overview of what the race and ethnicity of women served. As you can see, the majority, 53%, were white, although as I mentioned, a pretty sizable chunk, about a quarter, of the women served were American Indian, and that goes back to, as I mentioned before, there are 3 programs that are specifically providing culturally specific services for American Indian women, so that's a focus of the grant too. I should just pause and ask a second, are the slides, because I see the note from Sarah, are the slides not advancing? They're advancing on my end, but I'm not sure if you all can see the slides advancing on your end.
They are advancing, yeah.
They are? Okay. Well, great. And then again, just to give a big picture of who programs are serving, majority were between 25 and 34 years old. So one of the things we ask at all of the time points that we're collecting data, so again, at intake, at program closing, and then at follow-up interviews, is we ask women about their substance use in the prior 30 days to whatever that time point is. So when they come into their program, staff ask them about their use in the past 30 days, and you can see that 60% of women reported using 30 days before entering their program. And most commonly what they were using was alcohol, marijuana, or meth. And I want to spend a little bit of time on this because this is sort of highlighting something important that we found throughout the previous grant cycle and the current one. And what I think other research is showing us in that methamphetamine is among the most commonly used and also most preferred drug. And so, we hear a lot about the opioid crisis, and that is a real and important issue for us to elevate in our communities. It's obviously something we should be working on. But what we're seeing in our research, and what I know other research has shown, there was last year an article in the New York Times, NPR had an article, and recently, I think within the last week, the Brainerd Dispatch had an article about the resurgence of meth in communities, and in particularly in rural communities. So, if you're in rural Minnesota and you want to see that article, it was in the Brainerd Dispatch about the issues that Crow Wing County is facing related to meth. So I just wanted to spend some time on this slide to point out that the women that are being served under this grant are far more than opioids or other opioids or heroin, using alcohol, marijuana, and meth, and are preferring meth over other drugs. And so that's something that we just, as we're talking through solutions to the opioid crisis, wanting to keep in the back of our minds that this is another issue that we want to have funding for and find solutions for, is this resurgence of meth. Okay, so in terms of the general health and well-being of the women that are served, we asked a variety of questions, where you can see the green here represents sort of the determinants that would positively impact your health, and the red are those determinants that are more negatively impacting your health. The vast majority of women, when asked at intake, were living below the federal poverty line. You can see that it was 92%. And over 3/4 had at least one mental health diagnosis. And so you can imagine that these are factors that would seriously hinder, compound your ability to stay sober and have positive outcomes on your journey in recovery. There are some good news items in that, most people had health insurance at intake, and over 2/3 had at least a high school diploma. Some people had higher than that. So, but you can see sort of the general picture of health and well-being on this slide. We also look at, like I mentioned before, we do what we call a process evaluation to look at beyond what women are experiencing in the program, is looking at what the program model is or how the program is being borne out with women. And we can see that on average, women are staying in their programs for 5 months, and that most of them, 87%, or the majority of them, had at least one in-person contact per month. And this is important later on in the presentation, because what we end up doing is looking at outcomes by dosage, what we call dosage or intensity of services. So are outcomes different for women who have received more services versus those who've received less? And so we'll get to those slides in a minute, but this is just sort of showing the more processy part of our evaluation. And then the next slides really dig into the outcomes of women and what those outcomes look like over time. The most important outcome we track is, of course, substance use. This graph shows that between intake and closing, there is a significant drop in the use of substances among those served, which is a great outcome, and it makes sense logically that someone would be using less, or that people would be using less after between intake and closing. It also shows that participation in AA or NA, which is Alcoholics Anonymous or Narcotics Anonymous, goes up. And both of these are what we call statistically significant, meaning that these are actual changes that are occurring over time versus meaning that it's just a change due to chance. So big drop in substance use and a big increase in support through AA and NA. However, as you'll remember, we also look at changes across 4 time points, so intake, closing, and then 6 and 12 months after leaving a program. And what this shows is basically that maintaining sobriety long-term is very difficult. So while there's a significant decrease in substance use between intake and closing, we largely lose those gains by the time we get to 12 months or 1 year out of the program. And so if you're noticing, if you know the differences between those slides, what I should point out is, maybe I'll go back a slide, So these numbers here are based on matched data from women between intake and closing, and that's just over 2,000 women that we have matched data for at those 2 time points. And in the following slide, the farther out we go in time, the fewer women we're able to reach at all, have data for at all 4 time points. Well, that N size is much smaller. It's 137 for substance use. So that's just a caveat that there's a smaller N size that we're working with here on the full trend analysis, but it is still a significant change that there's this big decrease at closing and then a significant increase by 12-month follow-up. You can see support with AA and NA, it goes up and it takes a slight dip, but it's still pretty high at 12-month follow-up. About 2/3 of women say that they're in AA or NA. We talk to women in their follow-up interviews about what is it that's making it difficult to stay sober and what's helpful in maintaining sobriety. And in an open-ended question, the top 3 things that people identify as negative as what makes it difficult is the negative influence of other people who might be using, the lack of money or employment, and then also stress. And you can see, those 3 things may go together, but maybe not surprising, but those are the top 3 things that people identify as making it difficult to stay sober. And then far and away, the number 1 thing that people said was helpful in staying sober was their kids. 41% of women said that their children were what most motivated them to stay sober. And we always like to, sort of just showing charts and graphs and slides, show some of the story of what we're hearing. So I'll just read a couple of quotes from women who were talking about their kids in their follow-up interview. So, taking care of my kids, providing them with a stable home, not being like my mom. I want to be there for them when they need me. My mother left me in foster care, and that really sucked. So I want them to feel that they are loved and wanted by me. They are the most important thing for me in this world. And then just one more quote. My children, my health, because my children look up to mommy to be there. Everything doesn't work if you're using. I feel much better and look much better when I'm clean. So huge factor for women in staying sober is having their children and working towards goals to be a better mom for their kids. So another really important outcome that we look at is housing. We know through many studies and projects that we do here at Wilder Research and other studies that other folks do, how important housing is in determining health. And I'm just going to maybe pause for a second and make a plug for our homeless study, which we just released initial findings last month from our 2018 homeless study. But we're going to be digging into the data more in the coming months and plan to release several reports from that data. But we know that having housing is just so important in positive health outcomes, including sobriety. So in terms of women's recovery clients, we see so there are positive outcomes from intake to closing, and that women are more likely to be in housing at closing. They're more likely to have housing that they consider supportive to recovery and in housing that's considered stable. These are all significant changes from intake to closing. So good outcomes here. And again, we do a trend analysis from intake to follow-up and see that in general, housing is high. People are in housing at intake, closing, and follow-up. But the major caveat I want to point out with this trend analysis, it looks great. It's almost everyone is in housing at follow-up. However, the thing that's hard with follow-up interviews, as you can imagine, is that it's very hard to reach someone who is not in housing. So when we're looking at this data, this is overrepresenting people who are already housed. So we do an analysis of those we can find versus those we can't find, and those that we don't get to interview. And there are significant differences between those groups. So they're less like people who we did reach were less likely to be using substances at closing versus the people that we did not reach who are more likely to be using substances at closing. So that's all to say that this is a really great outcome represented in this graph, but I know that and acknowledge that we're missing a group of people who we were not able to locate as a follow-up interview. We also look at employment and saw some significant changes here. People were more likely to be employed at closing and at 6-month follow-up. It took a dip a little bit as a 12-month follow-up, but over time, this was a pretty positive change. Maintaining that employment trend line is tricky, and especially at intake and closing, really employment is pretty low. So even though it goes up between intake and closing, it's low. And so getting people employed and thinking back to that slide where employment and money and financial situation were, some of the things that were most likely to affect long-term sobriety for women in their own words and things that made it difficult, employment is obviously a huge factor in helping women maintain long-term sobriety. Like I said, some women come to their program through child protection, and because we're looking at women and the outcomes of their kids, we look at child protection involvement. And you can see there's a sort of steady decline between intake through follow-up and involvement in child protection. And again, this is significant, so that's a positive trend. We see that about 4 in 10 women at intake were involved with child protection versus about a quarter at 12 months follow-up. We also do look at a few outcomes for babies born during a woman's time in the program, and we found that most infants had a negative toxicology test. Of those who tested positive for drugs, the top 3 substances were marijuana, methamphetamine, and cocaine or crack. In the last grant cycle, we did an assessment that we called the Strengths and Stressors Assessment. We no longer do that in this grant cycle. We do other things to get at these factors. But what this really shows is we ask women to identify what they consider, or in a series of factors, whether they consider it to be a strength in their life or a stress in their life. And in most cases, as you can see, housing goes up and sort of goes down a little bit, but stays kind of high, and mental health goes up and sort of stays up. Income and employment is hovering around sort of the same trend. The one that I find really interesting here is that physical health for women goes down a lot after program closing. So 45% of women identify their physical health as a strength at intake, and then that number goes up at closing, but really takes a dip in the follow-up interview months. And so I don't necessarily have a good reason as to why that is. I mean, it's something that we're looking more into, or we want to look more into. We ask already a whole lot of questions of these women, and so adding more to get at why physical health goes down so much in the follow-up interviews. It's a balance of adding questions versus just letting that be what it is and trying to get at other things. But it is possible, too, that in other research we found a lot of times people will identify their physical health as good when they come into a program, and then through the course of the program realize that maybe it wasn't as good as they thought it was, or maybe they're feeling more comfortable with their caseworker and are more willing to report things that aren't going as well. And so that's potentially why we get a dip, but it really does go down quite a bit at the follow-up time point. So again, something we want to keep an eye on in the current grant cycle. As I mentioned, we do follow-up interviews with women to hear in their own words how they're doing and how the program impacted them and their kids. And we ask them at both 6 and 12 months to think back before they started the program to now. So compared to before you started the program, would you say the following things are better, the same, or worse? And you can see the blue circles sort of represent things that are more positive. People feel like their relationships are better, their living situation is better. We can think back to that sort of housing line and know that at least the people that we talk to, again, are feeling like their housing is stable and supportive. People are feeling like their mental and emotional health is a lot better since being in the program. But the things that are not are, again, their financial situation and their physical health. And that's exacerbated even more at the 12-month follow-up interview, where we see 20% of women say that their physical health is worse than from before they were in the program. We also talked to women about what the program helped them with, which services, and which ones were most helpful. So I think a really important component of these programs, and the most important thing that women say is helpful to them, is just having someone be there to provide emotional support and encouragement. So 87%, the majority, said that yes, their program helped them with this, that they were there to provide emotional support and encouragement. And that was the most common answer when we asked, it was the highest percent of people who felt that it was the most helpful to them. Getting or staying sober, it's interesting that 82% said yes, their program helped with this. In theory, hopefully that would be, a little higher, but 27% said that was the most helpful service that they got from their program. And again, just most often women felt that the staff support was the most positive service that they received. People said, the staff are wonderful, they're helpful and understanding and not judgmental. Everyone I worked with was very relationship-based. They were friendly and positive. These are just things we know through any number of programs that provide case management, the connection that someone has with their caseworker or the program staff that they interact with. Having that positive, encouraging relationship is extremely important in improving outcomes. So like I mentioned at the beginning of the presentation, we look at what we call dosage of, we do a dosage analysis of what does it mean to look at outcomes. Do outcomes differ basically between groups of women that received different amounts of programming? So you can see represented on this slide that we divided the women served into two different groups, high dosage and low dosage, and made some parameters around what those mean, and then sorted, put women into those categories that they fit these criteria. We've got our high dosage group, meaning that they were 90 days or more in the program, had 40 hours or more of contact with staff, and more in-person hours with staff versus the low dosage group. And what we see when we look at the outcomes of those high dosage versus low dosage groups is that high dosage clients are more likely to achieve positive outcomes, and particularly sobriety at closing 6 months and 12 months. So this is maybe not it's one of those findings that's very intuitive. If you think, well, if someone was in a program longer and received more services, of course their outcomes will be better. But it's nice to have that sort of borne out in the data that there are some statistically significant improvements or differences between people who had more program service. So again, their sobriety, they were more likely to be sober at the follow-up time points. They were more likely to be doing well at closing, and that's a measure that we have programs define for themselves. So each program that's involved with the grant sort of comes up with their own definition of what does doing well mean for their program, and then have them answer that question according to what their program's definition is. People in the high dosage group had more successful completion of treatment at closing, negative toxicology of both mom and baby. They were more likely to be employed at closing, had improved family stability, and were more likely to be in their own home and have no involvement with the criminal justice system at closing. So really important outcomes and to know that there is indeed a difference between those groups. We also look at a series of client characteristics just to see if there are any factors that might be more likely to contribute to positive outcomes. So is there anything about these women that is making them more likely to have positive outcomes? And I'll focus on the follow-up boxes here, so 6 and 12-month follow-up. But you can really see that there are some social determinants, like having stable and supportive housing, mental health services, employment, that make it more likely for women to stay sober in the long term. So if you are, in housing that's supportive to recovery, you're more likely to be sober at 12-month follow-up. And if you think back again to the things that women reported as factors that make it more likely for them to relapse, like their negative influences in their life, stress, and the lack of money or employment, this all makes sense. So the great thing about the work is that we know it, again, intuitively, but it's sort of borne out here that, if you have these things, supportive housing, employment, high dosage of service, and engaged in case planning, you are indeed more likely to be sober. So what does all of this mean? That's a lot of data. That we collect a lot and we report on a lot of data, but really at the end of the day, what does it mean? What have we learned from this grant evaluation? I think, especially one of the things that's always it makes my heart break is that slide at the very beginning of the trend line in substance use in the past 30 days. So maintaining sobriety is difficult. It's really hard, and people who work with these populations or have experienced this know that. And so the ongoing challenge is really trying to figure out how to support women in the long term with their recovery. We know that physical health is a challenge. We see that go down in the follow-up interviews, that women are reporting their physical health isn't as good in the follow-up months. I think even though the housing outcomes look good in the slides that I showed, I again want to emphasize that those are the outcomes of the people that we were able to get a hold of for the follow-up interview. But we know from anecdotal evidence, from programs, and just knowing what we know about housing, that finding affordable housing is hard, and not having housing is going to very negatively impact your health and your recovery. So making sure that women have affordable housing, can find housing that's supportive and stable, getting them away from those negative influences is extremely important. And again, obviously, we know that employment and outcome is crucial to reducing stress in folks and making sure they have the income that they need to find housing, and all these things are connected to get what they need to improve their health, to eventually help improve their path to recovery. So all of these things are interconnected. What we do know works, based on the analyses that I just outlined, is that the intensity of services really does make a difference. The longer that people are in the program, the more contact that they have with staff, it seems to show that this is extremely beneficial to outcomes in women over time. So making sure that women have that support both through their program and, again, in the long term. And as you saw in the quotes, women who have that positive connection with program staff find that extremely valuable. It is the most important thing to them about the program, that they have this emotional support and services from staff. We also, again, know that stable housing is stable housing that is supportive to recovery is important at program closing. It's one of those things that predicted sobriety at 6 and 12 months. Both having housing and then being in your own home, or permanent supportive housing, and having housing that's considered stable. I also think, in addition to the stable and supportive housing, having a connection to, and it's not on this slide, but one of the things we saw in the data is having a connection to mental health services and Alcoholics Anonymous or Narcotics Anonymous also predicted long-term sobriety. So again, having those emotional supports and long-term is helpful. The other thing, again, that's not on this slide is like I said, I don't know exactly how this is a way. It's hard to define it as a what works bullet, but knowing that their kids are the most important factor to them in motivating them to stay sober is important, and we want to remember that in our work moving forward. That just it's the most important thing to women is their kids, and however we can help them be with their kids or have positive relationships with their kids is extremely important in maintaining sobriety. So, and I guess that's the last slide. The other thing I want to say, too, is just remembering one of the challenges, before I wrap it up, that going back to that early slide of drug of choice and drug use, again, mentioning that another challenge is this sort of figuring out how to, in conjunction with working on the opioid crisis, really figuring out how we can get better resources to working with people who are using meth, and knowing that that's a resurgence that we're seeing, especially in our rural communities. So I think that's another challenge that, again, I didn't have on the slide, but wanted to just mention one more time that it's something that we're seeing in our data and that other folks are seeing in their data. So while we're talking about the opioid crisis, just remembering that there are other drugs out there too that we need to keep our eye on. That's all I have today. I am happy to take questions. I haven't actually been looking at the chat very much, so if there are questions that have come through, please repeat them, or I don't know, Sarah, if you want to read them out loud.
Yeah, so like Stephanie said, we'd like to open up the rest of the time for people's questions, and you can just type your questions directly in the Q&A box on the right side of your screen, and we'll get through as many questions as we possibly can with the time left. And so we have a question of, do you think that women are able to get a hold of, or do you think the women you are able to get a hold of for the follow-up interviews are doing better than those you don't reach?
Yeah, that's a really good question. I think that probably that's likely. Like I said, we do an analysis. I'm just going to pull it. We do an analysis between those two groups, and definitely, especially in terms of substance use, the people that we reach are more likely to have been substance-free at closing. So, yes, it may be sort of generally skewed towards positive outcomes, the people who are reaching for follow-up interviews. But, yeah, I think that's a good question. That's all I can think of.
Great. We have another question regarding relapse rate. Do you feel it's in line with other chronic illness?
I feel like it's... Yeah, so I'm not sure if I know the answer to that question. If it's in line, can you say it one more time? What was the question?
Yep, so around relapse rate, is it in line with other chronic illness?
I don't know if I know the answer. I have other colleagues in the room too, and we're not really sure, but I think it's a good question, and it's something we could look further into. And if the person who's asking that question wants to email me, that would probably be the best way, because I don't have a good immediate answer for that. I'm not sure. Okay.
Another question here. Were any post-treatment supports beyond 12-step resources offered to participants?
Any, aftercare services or longer-term services, you mean after they leave the program?
I think with the 12-step resources, they're talking about Alcoholics Anonymous, the 12-step program. Yeah, other past recovery.
Yeah, there are definitely other services that people get, and beyond just 12-step. I think that's always the most common one. But I'm trying to think of what we asked. There especially in the culturally specific programs, there are a lot of different services that people get through that. It is definitely not just 12-step programming. There are treatment services that people get through the program itself that are different, and they can be referred to other treatment programs in the community. But that is just the one that people most commonly get, I think, and that's why it's so prevalent in the slides.
Thank you.
And I should say, too, that if you're, and I'm struggling to remember some of these things because it's been a little while, but I think some of these questions could be answered, too, through the full report. So we do a big aggregate report, which is what these slides are based on, that cover the whole 5 years of the grant, and that's on our website, wilderresearch.org. We also do a report each year, and we do reports for each specific grantee. So, a lot of these results will vary by program site. So I don't think those site-specific reports aren't actually on our website, but you can find the full aggregate one that sort of shows more detail about, what are the other services that people are getting beyond Alcoholics Anonymous, for example. It's a really beefy report that you could spend a lot of time reading through and find some of the answers to these questions.
Great, thank you.
Yeah.
Another question, was Medicaid-assisted treatment offered to participants?
Yes, Matt, yep, that was offered, and we do ask a question. Yeah, we ask a question about it. It's a super small % of people who get it. But it is something that's offered, and it's something we ask about whether people get it or not. It's a very small %.
Thank you. We have another question. Does the type of drugs people use affect their outcomes?
Yes, it does. So we're digging a lot more into that in the current grant cycle, but in the previous one, and again, you can find it in the report, we saw that people whose primary drug of choice was either alcohol or marijuana were more likely to relapse. So, there's a lot maybe packed into that, but, and again, those are two of the most common drugs that people are using, but if you're using alcohol or marijuana, you're more likely to relapse in the analysis that we found last cycle.
Great, thank you for that. Another question we have coming in, any outcomes on those who are offered MAT treatment?
No, we don't. Unfortunately, it's just too small of a group of people to run any analyses on. It's really just, again, it's probably in the big report, but it's just too small, so no.
Great, thank you for that. Well, I want to thank everyone for participating in this webinar today, and a special thank you to Stephanie and her team for putting together this webinar for us. I'd like to encourage all of our participants to complete the survey about this webinar that you'll receive via email later today, and your responses will help us identify future topics you would like to hear about. And just as a reminder, today's webinar is part of the 2019 Public Health Lecture Series. We invite you to join us for the other events in the series, which you can see on your screen. Thank you again, and have a great rest of your week.
Thank you, Sarah. Thanks for having me.
Yeah,
thank you, everybody, for participating. Bye.